Exam 2 is a little different than exam 1. You're talking now about diagnoses and not just learning, memorizing information. Now you need to apply that information to different scenarios. As I was talking to my class on Tuesday night, you can learn this information from me, but listening to other professors and their reviews might open your mind to like, oh, okay, and understand it more. It sort of puts it in your mind better. So listen to more than one review. I appreciate that you're here with live. What I want you to do at any point, you're not understanding, stop, ask the question, all right? I do not mind. I don't get upset. It doesn't annoy me. My daughter made me prepared for this because she's the question asker. So ask whatever you want, stop me, because I'm sure somebody else has that same question. So exam 2, I'm still like, where is this quarter going? It's too quick. Come on, slideshow from the beginning. Yes, I can do it. Weeks 4, 5, 6. So I've already set up the review section for my classes. As I get this and it's downloaded that I can upload for you, I will place it on the same page. I'm also, when that happens, I'm going to put your Kahoots 4, 5, and 6 there. And I'm going to send it out to the other professors so that they can also post it for their announcements. Or I sometimes get sneaky and I just post it everywhere for everybody. So you might see that too if you're not in my class. Ines, do me a favor, put the other names of those other students in the chat box. I want them to get credit for being here too. So thanks. So again, come prepared. You know that. I know some of you are coming from another class before you come to mine. Make sure you stop a second, get something to eat, wash your face, something to drink, go to the bathroom, of course, and come to class as, comfortable as you can, that because we know that this exam, it is a lot of preparation, a lot of anxiety, and it's over with quick. So you want your mind as alert as possible. So eye conditions, we have amblyopia, we have strabismus, nystagmus. What are these? What do these mean? So we do have some definitions about them, but just don't remember a definition. So what is a lazy eye? It's amblyopia. That means one eye, the muscle's lazy, don't want to work, so it moves around. Usually it's crooked, like this child here. So as a nurse, when we recognize that, how are we going to treat it? Well, when you have muscles that don't work, we give it physical therapy, right? Well, we're going to cover the good eye and we're going to make that bad eye work. And we're going to do this in periods of time according to what the doctor wants. Maybe pat you on 2 hours, pat you off for 2 hours, whatever works the best, okay? And you force that bad eye to work. Strabismus is when they cross midline, which means they're just keep trying to focus. So you'll see them moving. So it's almost like a twitchy eye is what you see, but it's the eye trying to get there, like put it into focus. It's exactly what that means. Okay, early cognitive impairment. Now, cognitive impairment is when you aren't speaking correctly, talking correctly, it's just not in the manner it should. So what do you see? Well, you think cognitive impairment, you think Down syndrome. Isn't that the number one thing? So you might see those dysmorphic things. You might see the tongue hanging out. You might see that little flat nose, those almond eyes. You're going to see the fingers short with the creamy and crease in the hands. But besides those physical things, how do we look at them? And sometimes how do I identify them if they're really mild? Well, these children really have a hard time verbalizing their needs. Their language is really behind. And what is language? Well, if you can't talk, you can't speak what you need, what's going to happen? You're going to have behavior difficulties because you're angry. Like, why doesn't she understand me, right? Sometimes they'll sit in the corner, they don't listen, they get in their own minds, so they're not going to be aware, they're not going to answer to their name calling. We know gross and fine motors, which is how we measure cognitive delays, is all going to be delayed. Maybe they don't get up and walk till, a year and a half, turn over till 8-9 months. Fine motors using their fingers. They're not able to like button their shirt at 4 years old, right? And these milestones are going to be delayed. So with cognitive development, as I said, these are things you'll see with a Down's child. One of the things about Down's children, they've got this little flat nose and this big tongue in there, but it's mostly the nose that causes collection of a lot of secretions. And it causes a lot of upper respiratory infections. So number one, getting these kids learning how to blow their nose is probably one of the big things we need to do. So they're flexible. They could put their legs behind their neck, both of them, but be careful, they can dislocate their hips. They've got those big spaces on their toes between the fore and the big toe. It almost looks like your hand, but they are feet. And again, that underdeveloped nasal bone, which does cause those respiratory infections. Now, children generally, young children, have issues when separated from parents. That's just general. But then get a child with cognitive delay, as in Down syndrome, they're really stressed out when they're in a hospital and when the parents aren't with them. So as nurses, what would we encourage? At all possible, keep that parent or even grandma, grandpa, or maybe an older brother and sister over 18, stay with a kid, because that's going to decrease their anxiety and stress, and you'll be able to treat that child a lot better. So early intervention, when do we know to institute it? Well, we've learned a lot about growth and development, and we've learned about when they should be doing things. If they're not making noises, or if they're not, especially in that speech, it's a big deal. As I said, if they're not able to express themselves, this child's going to be a very angry, frustrated child, and you're going to have those behavior difficulties. So early intervention, early intervention. Now, don't just assume because they're cognitive delayed that it's a problem because of Down syndrome. Remember hearing, they cannot hear, they cannot speak, so always check their hearing or having speech difficulties. Now, autism. I did have on my Kahoots this week was that immunizations causes autism. And the reason for that is this. Autism, we're going to see some sort of signs before the age of 2 or 3 that they might be autistic, but the diagnosis is not made till 2 or 3 years old. What do we give at age 2 or 3 as in immunizations? They were going to give the varicella vaccine. It's a live vaccine. So some physician decided to write a research subject that said that it's vaccinations, immunizations that causes autism. It's only because of the time frame, because we give varicella at age 2 or 3, depending on if they've been sick, because we know all of the immunizations are a little delayed because they're sick somewhere, somehow, at some time. So autism is not from those things. Now, what do you see with an autistic child? We've sort of started to talk about it because they are cognitive delay. They do not respond if they're sitting there playing to their name. They just put themselves in a box, and it has nothing to do with their hearing, okay?
Hey,
Dr.
Ahead.
Bogart,
Go ahead.
I
Yes,
the
didn't.
ma'am.
only thing that we can see is what is the difference between anobula, strabismus, and nystagmus?
You have not seen it go. All right, let me stop sharing. Thank you. If you're
No
not watching what
problem.
I'm watching, I want you to be there. Can
Yeah,
you
I
see it
didn't see the
now?
PowerPoint too.
Yes, I sent you a message, but I don't think you read it.
I can't see it. When it
Oh,
goes
okay.
up to the screen, the whole screen is there. Thank you.
Gotcha.
Thank you. As I said, I appreciate you telling me if I don't do something right, or it's missing, or I forgot to, because I'm not perfect and I want you to have everything. So thank you. You get the A+ for today. because you said so first. Sorry, it's funny, but yes, thank you. Okay, autism. So like this boy, you could see he's in his corner and he's playing. You try to call him, he's not going to answer. They usually will sit there and do what we call those repetitive behaviors. Now, they don't imitate. They don't do what other kids are doing. There's not parallel play here. This is solitary play, okay? They're going to sit there and do things like this one little boy at this, the PPAC that y'all go, most of you go to for your clinicals. This little boy sits in the corner and he will take a bunch of toys and he might take like a fire truck, put it on a chair. Then he might take a doll and put it on the fire truck. Then he might take a ball and put it in there. Then he'll take the ball out, the doll out, take the fire truck, put it on the floor. He'll put the fire truck up, the doll up, the ball up, and then he'll do it backwards and forwards. And he could do it 20 times. This is comforting for him. So unusual repetitive behaviors. That's what that means. Again, they're not going to be able to walk and run. They're more clumsier than kids at the same age. They're not going to be able to talk, to express themselves as much as other children. They don't have that language. And again, playing alone. These children don't like what we call an aversion to textures, and it could be foods. It could be they don't like the stuff like oatmeal, or maybe they don't like chunky stuff. So these are things to be aware of. They don't like loud noises. They don't like lights. They don't like to be in a lot of people. All of these things are autistic. So they are those repetitive behaviors. They play alone by themselves. And these children, their speech, growth, and fine motor delays. We mentioned a little bit about immunizations, and it's something actually good to realize with MedSearch too. Immunizations, live ones, are not given to any child or adult that's immunosuppressed. Immunosuppressed could be that they do have sickle cell disease, or it could mean that they're on steroids, because steroids render you immunosuppressed. So all of the other families, whatnot, can take it, but a child who is immunosuppressed cannot take it because it can actually cause the disease. So how do you educate parents about kids getting immunized? Well, we know there are, and I've seen it all through the years, some parents do not want their child's vaccinated, which this is another, a can of worms that opens up, but it's their right, whether it's religious, whether it's personal beliefs, or maybe it's safety, and maybe it's that research study that they saw, but maybe they need more information. So it does lend those diseases that are really eradicated to be out there, like pertussis was out there. Polio is starting to come back, because a child not immunized can get the disease and still give it to children who are already immunized, because you still can get the disease. First vaccine given to any infant at the hospital before they go home, or the first visit, is hepatitis B. That's number one. Now, you have a child in the hospital and they're really sick, really ill. I mean, we saw that a lot with COVID, and now with that RSV that's really bad. We get these kids in the hospital, and how do we take care of them? Well, always nutrition, because you don't have nutrition, the body can't take care of itself. But this is just like adults. Use a draw sheet to pull them up. You don't want to just move them up and have their skin touching those sheets, because it could shear the skin off and cause a lot of sores. Use a skin moisturizer, keep the skin moist. Keep them dry. A moisture reduction pad, a diaper on young kids, but older kids, maybe a Chucks with maybe a diaper underneath there that you could change and change. Always turn these kids, we got to keep their body moving, their circulation moving every 2 hours, and always, prop them up with certain things, but like pillows and blankets and, You know, I even use sometimes stuffed animals to get them over, but make sure that we're not putting things in the same place, causing pressure areas. You know, children do have a coccyx. They do get the cubitus ulcer and coccyx and heels of the feet, and be aware of that. Just because they're a kid doesn't mean they're not going to. Now, children, getting them in the hospital, you got to do your primary assessment. You have 24 hours usually after admission to get it done. These children, a lot of the times, are scared to death. They're in this different place, different people, different routines, different everything. So how are we going to get to listen to their chest, listen to their bellies, listen to their pulses, you know, feel their capillary refill, all those things? The best thing is what we call let the parents hold them. And this is comfort care. This is something that I firmly believe in. My dissertation for my PhD was the critical behaviors, attitudes and behaviors of school-age children for injections. And in my research, what did I find out? I found out if a child was held, even older school-age children, or at least hugged by the parent sitting next to them during these procedures, there was less fear, stress, and pain before, during, and after. So in the lab, it works amazing. And I did research, I proved it. Now we've talked about a lot of play, but let's get a kid, put them in the hospital. Let's say they're just diagnosed with leukemia, and it's going to be, you know, a lot of blood draws and blood transfusions and chemotherapy and all of these things in and out of the hospital. And it becomes overwhelming for children. So how do we, what type of play lets them reenact how they're feeling? And it's dramatic play. Yes, we have expressive and creative that does those things, but dramatic play is telling me what it is that's really they're afraid of. So any kid who is in a hospital, let's say they're in there for open heart surgery and it hurts. I mean, even cardiac caths, when they put that big needle in their groins and there's 2 catheters, it is really tender, swollen, a little ecchymotic post-procedure. It hurts. So if you want to be able to do everything right, turn, position, cough, prevent complications, you need to decrease that pain. And pain can be decreased by many different ways. Well, yeah, you can give them narcotics, and you can alternate that and give them some Tylenol. But what about distraction, right? How are they going to take a deep breath on that machine, that little whatever, 3 balls or whatever it is today, blowing in and out? Let's make it into fun, make it distraction, but medicate them first, decrease the pain. Then they can cough, deep breathe. They can get rid of that rhonchi. They can prevent pneumonias. They can, let's do pedaling the bike type of things, you know, to prevent those clots in the legs. So medicate them for pain, and these kids will get up, get out of bed, and they'll do play with you. Because remember, I played every day I went to work with children, which was the best thing. Remember, Tylenol can be given to all age children, but you cannot add pediaprofen, ibuprofen, Motrin, Advil till they're 6 months old. So for the first 6 months of life, they are going to be getting just Tylenol, okay? And it's whatever the dose is, 10 to 20 milligrams per kilogram. And these children, some of them don't want to swallow it. So what do? You're going to teach these parents, take a deep breath in, they're going to give it, right? And then you look at them and real hard in their face. And what happens? It's a puff of air and and they swallow it, and it works. And this can be used all the way up. Preschoolers, I've used it. Some kids hate medicines, they won't. So you get it in there, but they're not going to swallow it no matter what you do, right? Puff it in their air, that air into their face, and guess what? And they get it. And this is what going to do. It's going to decrease the pain, decrease any sort of complications. Now, children do get IVs, they can put them anywhere, but our biggest concern is infiltrations. Now, 10 mLs of fluid on you or me is nothing, but if it is a 5-kilo kid, that actually can cause a lot of swelling. So what do you do first when you suspect or see swelling before you even assess? Turn it off. You don't want any more fluids going in there. Then if it's just a normal IV and you know you can take it out, elevate it, put warm on it, and you have to change the site for the next IV. And of course, notify the physician if it's more swelling than you would have wanted seen. I mean, sometimes you might see a red streak. Sometimes underneath the little plastic, you might see a little fluid. These things, number one, stop the infusion. Now, one of the ways that we feed children can be just with a gastrostomy tube. Some of them are intermittent and there's some are for life, depending on patient condition. Now, there used to be all sorts of procedures that we used to do. Today, soap and water. You don't have to twist it. Don't do any of that stuff. Just clean it, soap and water, put a new little 2x2 or 4x4 there, and it is fine. These kids can lay on it. Make sure it's secured to the body somehow. I mean, the new mix where it's just left with just a little thing sitting there, you need nothing. But the ones that hang out that looks like a Foley catheter, sometimes we'll put mesh around and it will hold it in place. So just so it don't pull. 1 second, please. Sorry, my little boy fell down and got a knot in his head. He got a headache. So what do you think I told him to give? He's 5 years old. He's got a big, like a good $50 size, and it's swollen. Tylenol or Motrin, what would you give?
Motrin,
Why?
inflammation and pain.
But it also causes more bleeding. I gave Tylenol. Make sense? Yes, I agree.
Got you.
Inflammation, pain, fever, yeah, fever, no. But because it's, ecchymotic and it's new, I don't want more bleeding. So Tylenol is a better choice until tomorrow. You
Thank
learned
you.
something today. No, you're welcome. I think all the time. Okay, oxygen. Now, children do need oxygen for many different reasons. And how do we give it? Well, if at all possible, an oxy hood is the best. Why? They still can suck their fingers, they can blow bubbles, it's clear, they can look around, they can have a pacifier. That is the best. We also can monitor the amount of percentage given there. So it is well tolerated and we can monitor it well. There's a little probe they put underneath there next to the kid's head. Nasal cannulas also can be done, but this thing is blowing air up in there. It irritates. And you usually tape it to the skin and they stick their fingers up and they can rip it off. So it is not as tolerated. I mean, a ventilator, has anybody ever been intubated? I have. And you feel like you're gagging and choking. So not that. And then there's also CPAP or that nasal continuous positive flow. Again, it's something stuck up there and it's bothersome. Now, look at this oxygen cannula just to show we can measure oxygen well. According to the amount of flow, we know what's going to go in there approximately. But can you imagine giving 10 liters of oxygen to a little baby? You're going to blow, too much. So actually the oxy hood is best. Now, we know infants have a very low, not as good as we want immune system yet. And it's just normal. So if a kid gets a urinary tract infection, we can smell it. The kid has fever, they're symptomatic. We need to get a urine specimen that's going to tell us what germ is in there. Now, we think we know what germ, what bacteria it is, and we'll place the child on that antibiotic. but we want to be sure. So the best way to get the most accurate specimen so that we know that that kid's on the correct antibiotic is going to be doing a catheterization. Now, if we get one urine, one course of antibiotics, it's the best for the kid. We don't want to prolong it with the wrong antibiotic. It could hurt the kidneys and we don't want it. So you can put some numbing cream there, lidocaine, before the procedure and then do it. But I usually have not done it. It's usually done quick. Make sure you explain this to the parents, especially with females. They think they're going to be devirginated. Okay, that's always what I heard. And if you've ever had a male baby with a father standing there, they're crossing their legs and they're touching their private area going, oh my goodness. And I'm like, you don't have to watch. Again, during this, have the parents holding that child, having them talk with them, you know, it distracts them. And it's done so quick and it's over and there's no pain afterwards. And we got a very correct specimen to know that we are on the right antibiotic. Now, infants, and you know, even up to 1 or 2 years old, we just need a simple CBC. It's only 0.4 mLs of blood. And they're little tiny little microtamers we use. So we do, instead of a stick into the arm, into the anticube, we're going to do a heel stick. Well, we want to get the blood come out as quick as possible. And we don't want to squeeze hard to get it out. So what do? Most hospitals have approved warmers. Usually they're these little bags you crack, and then I put it in a towel or I put it in a blanket and I put it on that foot, you know, 30 minutes or even 10 minutes before I want to give it. And it dilates the vessels of the heel. Only use the sides of the heel, not the back, because you can hit the bone and then cause an osteomyelitis. If you have that foot, and this is a trick I'm going to share with you, it's not in the book, but if you hold it down below the heart, like I get on a chair, have the kid up on the stretcher or wherever they are, the table, hold that leg down and slowly, just very gently squeeze. And I've warmed it, and a little alcohol also causes the bleeding. You're going to get it really quick. So that's a trick. Hold it down, not up in the air. Intake output. We know sometimes intake and output is really important. I mean, I think the best way of, especially when we're looking at large volumes of fluid, daily weights is number one, how we look at intake output. Are we gaining fluid? But anything by mouth, it will be counted as intake. And even sometimes medication, sometimes they're 2 or 3 mLs. If you've given it 4 or 5 times a day, that could be a ½ ounce of fluid. And in small kids, it could mean something. Output, we check everything. And I think in adults, ice, in the adult world population, ice is half the volume that you get. We count as intake when you need it. We do measure urine, stool, and even sweat sometimes if we need to. Put a diaper on the child. We know what they weigh dry. Weigh it when it's wet, and the difference is going to be the urine or the stool output. If they're in something where they're sweating a lot, I put a bigger diaper underneath, and I will measure that. And it gives you an idea of output on these children. So again, I was talking about giving medication, you know, as they get older, you know, give them, go in there and say, okay, we're going to give you a medicine. Do you want a liquid or you want to chew a pill? Be direct. Don't give them a choice, as in you're going to take it or not. Do you want the orange one or you want the red one? You know, those sort of choices only. And then If we're giving it to the child, gave them liquid, they're not swallowing, we know what to do now, right? I used to do it, but today we're not going to blow in kids' mouths anymore. It's just, infection control, but a parent can. But show them before giving the medicine. Now, stress and hospitalization, as I said, kids freak out. It's a different place, it's a different bed, different noises, different smells and sounds, and they're scared. So separation anxiety, mom and dad not there, is the biggest stressor. So leave that child in the room with the parents. The parents should be there. We know cognitively impaired children are the ones that stress the most. I mentioned this first in the Downs area. Preschoolers, toddlers also. This is an area where you see it a lot more. And actually males more than females. So what happens? A kid gets into the hospital and they're really upset, and maybe the parents have to go to work. Oh my goodness, could you imagine? Or they have to go to the other kids' band recital or whatever. These kids get upset and they're not going to verbalize it because they don't know exactly. So what do? They'll regress. And it could be start sucking their thumb again, or maybe they start being incontinent, needing diapers. These children with this anxiety, sometimes, again, it's doing something with that distraction. I think the Mario Brothers game for those kids, even older preschoolers and even older toddlers, give them an iPad, a game, you've distracted them, they're not going to be as afraid. But there are different stages of being hospitalized and that response to it. And if we start seeing these children being incontinent, sucking their finger in the corner, we know that we need to do something to get them to, at least for a moment, not be into that regressive type of mode. We know kids do get into these temper tantrums, no, not mine, and running away, and they really, really get scared. So again, I've talked to it 100 times. My classes know it. Number one, before you do anything, get on their level. Sit on the floor next to them. You don't have to try to say, if you do this, I'll do that. No, walk in, start, oh my goodness, those cute little cheeks, that I love Spider-Man. Who got you that shirt? I've one at home. Maybe I'll wear it tomorrow underneath my uniform. Get them out of it. Preschoolers understand this stuff. After you're on their level and they're getting a little bit more okay with you, then give them the equipment. Let them touch it. Let them do the blood pressure on you. Let them push the buttons for whatever. Because remember, especially if they're in the hospital and the parents aren't there, that is the biggest stressor. I mean, those preschoolers, no, mom and dad are gone. I mean, toddlers, you might be able to distract them a little, but preschoolers is the biggest. Now, hospitals for the school-age children, they're older. You can talk to them a little bit more, but how do you keep them not to be as stressed and feared and you regress during a hospitalization? Keep them on a same schedule that they're used to at home. If they're used to waking up in the morning, taking a shower, do it. If they have an IV in, have their hand or whatever sticking out of the shower and help them, or have one of your assistants help them do it. Try to get them the same foods if all possible, and try to have them the same nap times, the same dinner time, the same breakfast time, the same everything as possible, because they know what's coming next, so they won't be as stressed. Have the parents be involved. Your parents are your biggest eyes to your child, your patient, and for things going wrong, they can see it first because they're there most of the time. So have them involved. How do you do that? Well, you're going to teach. You're going to teach them what you are looking for and what that means. So you teach them and then have them repeat it so you know they're understanding it, okay? And again, if they're going to be doing like maybe changing a dressing, why can't they? If it's a simple just change a dressing, well, tell them how to do it once as you're doing it. Have them do it, you watch, and then they could do it on their own, but you tell them when you want it to be done. And again, I can't tell you more than 16 times, have the parents stay with them as much as possible. Now, ear infections. Ear infections hurt. Ear infections are a bacteria. Now, it's obvious if you see an eye that's got all of this crust and mucus, serosanguinous fluid coming out. Many times you don't see this. You might see a younger kid. How would you know it's pain? Well, their head and they're shaking it, or maybe their hand is hitting it, or you see them grimacing, crying, that little chin quivering, and their legs, arms just moving. You might see that. Sometimes they're just whimpering, they're in so much pain, they can't even move. So first thing we do for an ear infection or suspected, medicate for pain, okay? Get that kid comfortable. I have seen children walk into the ER screaming, in pain, just whimpering, being held in the parents' arms, and 20 minutes after I give, and I usually give ibuprofen because of the anti-inflammatory, like we said earlier, right? Perfect medicine, anti-inflammatory, as long as they're 6 months old, right? 20 minutes later, this kid is up and moving and will be able to drink fluids, and like you're not the same kid that you were before because their pain is gone. Also, remember, we need to teach a parent about ear infections and the importance to medicate them as soon as we possibly can, for pain, and to get them to the doctor for antibiotics. They will always get an antibiotic. They don't always have a fever with an earache, okay? They don't always. And chronic ear infections can cause hearing loss. How do we treat it? We treat it with antibiotics and then maybe tubes and surgery if they're chronic ear infections. Now, bronchitis is a dry cough that gets worse at night. It's called tracheobronchitis or bronchitis. The bronchus is irritated and cough, 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 cough. It is at night when you want to sleep and you can't. Many of the times, again, this one don't have a fever either. It's just a cough. How do we treat it? Well, adults always Z-Pak and some sort of codeine cough medicine, and it usually will go away. It's usually they always treat it with an antibiotic, but it doesn't even really matter, viral or not. They always do treat these with antibiotics. Croup. Well, tracheobronchitis is bronchitis, right? Laryngeal tracheobronchitis, it's the whole upper airway down into the bronchus. It's swollen, okay? And you will know a kid has croup because you can hear him coming down the hall. It is a very familiar sounding cough. How do we treat it? Well, it's usually a virus, okay? No big deal, right? Well, if it continues, it's swelling, it's in the larynx, it can cause you to go into respiratory distress, and you could actually die from croup, from epiglottitis it turns into. And so we need to treat it as quick as we can. And how do we treat it? We're going to treat it with a steroid. We're going to be given, maybe, if it's that bad, a racemic epinephrine aerosol, which goes directly to that larynx and decreases swelling. And usually these kids do really well. So Laryngeal tracheal bronchitis. The larynx, the trachea, and the bronchus are swollen. You hear it because it is a inspiratory stridor, okay? Asthma is that expiratory. This is inspiratory stridor, and it can get worse and turn into epiglottitis. Treat it, steroids, and maybe a racemic epi. Now, this week, y'all are doing the case study on cystic fibrosis. And cystic fibrosis, sometimes we don't know we're going to get it, or our baby's going to have it. But an infant, newborn, who doesn't stool in the first 2 days of life, they're going to say, let's test. This is one of the things they test for, is cystic fibrosis. Now, how do we test for cystic fibrosis? Well, I've told my class, have the parent lick the kid. If it's salty, it's cystic fibrosis. But you're not going to tell the parents to do that. But if they did, they're losing salt like crazy. So we do a sweat test. It's called a sweat chloride test. And literally, they're looking for salt because they lose it. It is inherited. It's both parents, it's a 25% chance, just like cystic, like sickle cell. 2 parents with a trait, it's 25% of each child having it. Same sort of numbers here. So what are some things we see? Well, cystic fibrosis is 2 components. It's the lungs full of mucus and phlegm. I call it a petri dish, which sits there and harbors bacteria, gets thick, and doesn't allow you to breathe well. So how do you think we're going to treat that? We're going to give a lot of chest physiotherapy, aerosols. That little thing you see, that black thing and that pink thing, it's a vibrating thing, and it vibrates really good. In fact, most kids will go to sleep on it. It's that good. At the same time, you give an aerosol, and as you're doing that vibrating in that chest, the aerosol can get into all of those little nooks and crannies, and they can spit up all the mucus. So that helps with the respiratory, aggressive physiotherapy, chest physiotherapy. Now, the other thing is that the body needs pancreatase enzymes to help have food ready available so it can be used. Your fat-soluble vitamins are not taken into the body. They are expelled through stools. It stinks. It's this bulky, like foul smelling stools that come out. So these children are not getting good nutrition at all. So these kids do need high calorie, high protein, high fat diet, right? And we are not going to limit any salt on these kids because they're losing it, right? You can lick it off of them. What else? Pancreatic CF, again, extra salt in their diet. We're going to have them on the supplementation for your fat vitamins. And we, again, are going to be given aerosols to thin the mucus, to expel it, along with giving that chest physiotherapy, keep that airway open. I met one family that had 3 boys that all had cystic fibrosis. And the last one they tried for that 3rd one, he also had a cyanotic congenital heart defect. That kid was really difficult and very brittle to take care of. So how do we treat that nutritional part, the small intestines? Remember, small intestines is where all of the absorption of all the vitamins and minerals to the body are. I mean, that's where your gallbladder is, and that's where your pancreas is, and your liver, which all secrete some sort of secretions of bile and the pancreatase that helps with these absorptions of these vitamins and minerals. Well, in cystic fibrosis, we need to give them something that helps them digest their food better. And it's called pancreatase. It can be a capsule or it could be a powder. The capsule has little beads in it. You can open it and sprinkle it on the food. This is one case you can do that, okay? Another thing is you might put the powder and put it there. But the one thing with powder is caustic to the teeth, can cause the teeth to be, the enamel to be eaten. So we need to make sure that mouth is rinsed afterwards. And the one thing, and it's given immediately before they eat. So 30 minutes or less before. Whenever you have enteric coated anything, you're not going to chew or swallow it. They can't get it down, sprinkle it on the food, whether it is the capsule, beads, or powder. And the one thing we do forget, and it's something that I always remind these physicians, do a drug level, because these kids are getting bigger. This kid's been on the same dose for 2 years. They need more, okay? Always remember they need more as they get older. Now, cystic fibrosis, I mean, girls are not as bad, but boys. But when we think cystic fibrosis, usually they just put them in one compartment. A child will really have a hard time having children. And many times these kids are living a normal life because they're taking care of their lungs. You know, they're doing all those things. They're giving themselves those pancreatases and, you know, taking their fat vitamins to make sure that they have proper nutrition and eating high calories. I mean, infants will immediately put them in a higher calorie formula. And even if they're breastfed, we do have a way to put in more calories into the formula or the breast milk. A little bit we put in there, and the rest they can nurse off the mother. But many of these men, and of course girls, want to become pregnant. They want to be normal. You know, we're going to try to treat them as normal possible. They want to get married. They want to have kids. So the way to that to happen is these children, which are now adults, need to have a double lung transplant. 1 year after that transplant, they're going to have higher chances to become pregnant and to be able to be a mommy and daddy, okay? So they have to go through a lot, but I'm telling you, many of these kids do because they really want that family. Now, tonsils, tonsillectomy care. Now, tonsils, we'll take them out when you're having multiple tonsillitis. You know, and we know it hurts, especially that strep tonsillitis. It really hurts. And it's those big things in the back of the throat. So there'll be an outpatient procedure where they'll go in and they will take those tonsils out. Now, after they come out of surgery, the throat hurts. But remember, there's areas on either side which have a huge clot on it, which is like a big scab, which stops the bleeding, okay? If we didn't have that scab there, it would continue to bleed. So our goal is to keep it from bleeding. And I have seen a hemorrhage from a week after tonsils were taken out. So it's a very serious thing. They need to drink fluids. Cool fluids are always the best. Popsicles, ice chips, any cold drink, whatever. My grandson is into those fruit bars, those ice pops. He loves them. But remember, nothing red. You want to know if it's bleeding, right? If it's red, you're going to see red stuff come up. Another thing, post-operatively, and younger kids don't like it, but older kids will, put an ice collar. It's just a big round thing you put on the neck, and that does help with pain. Now, a lot of times they get pain up into the ears because of the position of tonsils and where the ears connect with the back of the throat. Older kids, they can chew gum. And that chewing gum is like going up and your ears popping when you go up in the airplane or down underneath the water. So they can chew gum, that helps. They can have an ice pop, nothing spicy, no citrus. Orange juice, lemonade, just don't do it. It's going to hurt. And the other thing with these children, if we notice they're swallowing a lot, guess what they're swallowing? Blood. This one I was talking to you about, it was a little girl who was 9, came into the ER. She had just gone to her ENT, and she came in with a towel full of big clots, which looked like liver. And she kept vomiting and vomiting. I immediately picked that girl up and carried her, brought her back into the trauma room, started an IV. She was going into shock. The 9-year-old, heart rate of 140, blood pressure of 70/50. I threw in a liter of fluid, got her stabilized. She went to the OR, they recauterized it, and she did well. 1 week post tonsillectomy. So they do need to rest for a couple weeks after surgery. Now, many of us use nose sprays when we're breathing with a cold and our mouths are wide open because we can't get air in our nose, and then our mouth is all dry and we just want to breathe from our nose. So we use nose spray, Afrin. There's even ephedrine that we can use, or, 4-way, one of those things. These things cause you to breathe, but after 3 or 5 days using it continuously, when you stop, you are going to be even worse of not breathing through your nose than when you started. So warn children, do not use it more than 3 to 5 days because you will end up worse. Asthma. This is one of those, diseases, conditions in children that many children do have it, and adults. What it is, it's a hyper-responsiveness in your bronchus, which causes swelling, and it causes, you can get air in, but you can't get it out. So this is your prolonged expiratory wheezing. What do you see? This kid's going to have this loose, dry cough, 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 cough. And as they breathe out, you might hear it's a wheeze, a wheeze. So wheezing, prolonged expiratory phase. Your discussion question was on asthma, and it talked about a lot of it. And there's a peak flow meter, which is a great tool. They're giving it now to the family, to the child, to monitor. And you monitor when the kid, how much air is moving when they're feeling well. And they do it every day, like brushing their teeth. And if they see the amount of air moving decreasing, guess what? Something's going to happen. So let's start the aerosols now before we become more of the get worse and go into maybe status asthmaticus, which can happen. Now, with these children, what did I want to say? What did I want to say? What did I want to say? I want to remember something very important about asthma. Okay, when you're a nurse, you're taking care of these children coming in you're in the emergency room. You hear a kid come in and you hear the cough. When you start seeing retractions, especially the one between the clavicle bones, these kids, it literally will pull back, almost what I call to the backbone. You'll see that nasal flaring, okay? You're going to see that cough, that retraction between there, the supraclavicular and intercostal, the abdominal breathing. This kid needs care now. This kid is serious. So those retractions are when they're at that point where you really need to make that child your #1 priority. Chronic non-productive coughs, that expiratory wheezing. This is not a virus, bacteria. It is some sort of antigen. It's making a hyper-responsiveness. So how do we treat these kids? Well, as we're having this cough and we feel these tickle and what's starting not to feel good, we're going to give that rescue, and that's that albuterol. And the thing with giving albuterol and giving it to younger children, and even a lot of older people, you give the dose 1, 2, and you breathe in. Many children, even adults, can't walk and chew gum. They're going to push it and they're not going to get it. So you'll see kids come into the ER saying, yeah, they've been sick with asthma. They've been taking their albuterol, but it's not getting better. My first question is, so how did you give this albuterol? Was it an air? I mean, sometimes younger kids get aerosol, but because of the time constraints it takes, it's like 10, 20 minutes to give these things. They just give the little meter dose inhalers like this little boy in the bottom right. But you see how he has that little spacer? You put it close, you hold their head up to it. You give the 2 puffs, which is if that's the dose, and then let them breathe in and out. Now, many times they'll cry, but you know something? They're taking deep breaths. They're getting it in there, so it's going to work. Now, prevention of bronchospasm is done with some sort of corticosteroid. In adults, you see Symbicort, Advair, Brio, morning and night. It's got a little steroid in there, and that helps keep the lungs calm, that they won't go into, it keeps the lungs happy. In children, a lot of times we see Pulmicort morning and night, but there's different types of meter dosed inhalers for prevention to keep the lungs calm. And then there's the one for rescue, which is your albuterol. During an acute phase treatment, as many albuterol aerosols as they need, or even dosed inhalers. And we're also going to be giving them corticosteroids. It could be IV, Solumedrol, or it could be just prednisolone that we give, Orapred, 2 times a day, 4 or 5 days, and they do okay. Plenty of fluids too, right? Croup. Inspiratory. We've sort of mentioned it a little bit. It's laryngeal-tracheal bronchitis. It affects upper airway. And how do we treat it? Well, always anything with upper respiratory, of course, maintain your airway. Some of these kids, just give them those little steroids, a little epi aerosol, and they can eat and drink normally. Some kids, if they're further along to the point of epiglottitis, these kids will need IV. And if they need, they can have some oxygen. And we do give this little mist that can have oxygen in it. There's like these little tents, sometimes masks. Those things work great. As I said before, croup, if we don't treat it, it's an inflammation of the upper airway, and it could get to the epiglottis. And then we've talked about epiglottitis. It's covering the larynx. I can't breathe. So this is severe inspiratory stridor. You can't get air in. You can't get it in at all. Out is easy, but can't get it in. These kids sit forward in a tripod, trying to find how they sit that air can get in there. Again, how do we treat these children? Well, number one, at the bedside, you need to have something to be able to intubate immediately. Many times you can't intubate, there's so much swelling, so have a tracheostomy tray there ready to go for these kids. And as a nurse, you're not going to look in there, only the physician. RSV, respiratory syncytial virus. I mean, this year we got a bad one out there. So very important for children. Now, which children? Those children who are already immunocompromised, a kid was premature, already has respiratory issues, cardiac child, any of these kids who are already fighting something else, it's going to be something that they need to be prevented from having it. So we know that the changing of season, now I live in Florida, you don't see it as much, but what they say is like late fall, winter to early spring is those times where this is an issue. So what we do is we're going to be trying to prevent this in children that are more apt to get it. It is a monthly immunization, and the monthly immunization is called Synagist. The other name is Pevizumab. It's one of those biologics. Those biologics are there to prevent them from having it. Okay, So Synagis prevents RSV. And these children, what's the big issue with RSV? It's all the mucus. We know infant, and this is the first year of life, first year monthly, okay? The thing with RSV is that these children tend to have a lot of mucus. Infants, they're obligatory nose breathers. They don't know they have a mouth. And if your nose is full of mucus, they can't breathe. Well, if they can't breathe, they can't eat either, right? So they're not eating. And, you know, we know nutrition, they're just not getting it. So we want to prevent it. So how do we treat it? If we get it, it's a kid who's, you know, not one of these children who need this immunization. Well, we're going to keep that airway clean and try to get the secretions out. Usually, and you can't over suction, okay? Before they eat, suction the nose out and let them eat. Usually there's low-grade fevers, so make sure that we do medicate with either Tylenol, Motrin, both, whatever's appropriate. Mononucleosis is a virus. It is called an Epstein-Barr virus, which just means it's a virus. And Epstein-Barr is always this one, you just feel tired and weak and you just feel horrible. So symptoms, what do you see? Well, this kid will go to the doctor complaining of a sore throat and a fever and just tired and feeling horrible. You might see some swollen glands. You might see the abdomen swollen. And these kids end up going to the doctor and he said, you have a virus, Tylenol, Motrin, and rest. They don't know it's mono yet. They just think it's a pharyngitis. They go back again, still continuing, no improvement. They say, well, we don't know why. They've tested for strep, they've tested for RSV, influenza, they've tested for everything and it's nothing. So they're like, you know, at first just the virus, nothing. When they come back, they say, all right, well, we don't know what's going on, but let's give you an antibiotic. A couple of days later, they're still sick, even on antibiotics. And maybe now they're even vomiting and diarrhea because of the antibiotic, right? They say, okay, still sore throat, still these symptoms. Let's go ahead, let's do a lab test. They do a lab test called a monospot test, and they find it positive. The big thing about mono is your spleen becomes this big balloon in many cases, and the liver too. And the big warning, the big teaching we need to teach parents and children is to know contact sports and to protect their abdomens from injury. Telling their brothers and sisters not to be roughhousing and rolling around on the floor because that spleen or liver can burst and you'll be dead. So it's a virus still. How are you going to treat it? Tylenol, Motrin, fluids, rest, and cannot go back to any sort of sports until cleared by their pediatrician. Now, yours and mine favorite thing, cardiac conditions, right? Well, what do we need to know about cardiac conditions? Well, the one cardiac condition that you will see, and you're going to see it a lot, even on your NCLEX. That's why I go into it quite, a lot. Tetralogy up below is a right-sided disease. So you need to look at your how blood flows through the heart. Where does it go? What valves are where is very important for this exam, okay? Which valves are where? Between the right ventricle and atrium is your tricuspid valve. Between the left atrium and left ventricle is your mitral valve. Going out of the right ventricle is a pulmonary valve, and that pulmonary valve goes to the lungs. And that's the whole thing with tetralogy. So you have this pulmonic valve and this pulmonic stem going to the lungs, and it's either small, stenotic, which means it's open but small, and then something covers it. Sometimes it just closes off completely and not a drop of blood goes up into the lungs. I have seen children have a tet spell or a blue spell go from O2 saturations of 100, go down to 10 in less than a couple minutes, like 2 minutes. I mean, it was quick. And you see these kids go from pink to blue, to black. I mean, it's quick. So tetralogy spells, how do you treat an infant with tetralogy spell? They're having a tet spell. Okay, the doctor's not there, it's you. And you need to do something quick. There's no oxygen, right? You do what we call a knee chest. You can see this infant here, knee chest, or you can have them on their side and take knee to chest. What's interesting, older children will do what that little boy up there is doing. They squat. What does this do, this putting knee to chest type thing? Well, there are pressures in your abdominal cavity and in your chest cavity. And that moving, that quick pushing them together changes pressure and usually pops whatever is covering that pulmonary artery away, and then blood will flow. Many children with congenital heart defects, which this is, tend to be smaller. Their hearts work harder. They have less oxygen saturations, so they don't have energy. They don't eat as well. Therefore, they're not going to gain weight as well. So these kids are at the lower percentiles, all because of these cyanotic episodes, because your body needs oxygen to be able to do what it needs to do. And as an infant, their big need to do is eat. So acyanotic and cyanotic. Acyanotic is just holes between the heart, which is the atrial between the right and left atrium, or ventricular between the right ventricle and left ventricle. Now, I mentioned to you all something called that PDA, and a lot of you are like, I just don't get what a PDA is. Well, just think about a rescue area that can give oxygen when all else fails. But this usually closes at birth. Now, mommy produces this hormone called prostaglandins. And this is part of the fetal circulation. And it lets stuff from the lungs, the pulmonary artery, be able to get to the body, which is the aorta. So it's this little tube, it connects it. What does it do? It gives oxygen and cardiac output to a heart that's not getting oxygen any other way. If you have oxygen, you'll have cardiac output. If you don't have oxygen, you're not going to have output. So a PDA is kept open by prostaglandins in intrautero, and immediately after birth, not too much long after, it's mommy's giving them that prostaglandins. Now, sometimes the heart has a condition where they're not getting oxygen. Well, one of the big ones that we think of is transposition of the great arteries. If you have blood just going around in a circle from the aorta, is switched with a pulmonary artery. So you've got off the right ventricle goes to the body, but that's the unoxygenated side, right? That's the right side. But now the pulmonary artery is on the left side. So all you have to do is have it just go into the lungs. So there's no oxygen mixing. What's going to the body? There's no oxygen. Guess how we can do that? We're going to give a synthetic prostaglandins, which is going to give oxygen to the body. It's a slow, continuous IV drip of prostaglandins, just like what mommy had, what mommy did to keep it open when they were inside intrautero. They kept the baby living when they're inside mommy. But now on the outside, mommy's gone. So her supply is gone, but we can give it. And what that does, it gives oxygen to the body, it connects it, and it gives cardiac output. Now, one of the other things is to think there's two different words. There's a stenosis and there's a atresia. Stenosis means a narrowing, small. means still blood is getting up there somehow, okay? Atresia means a, without, nothing. There is no connection. There is no blood getting through. And the one that we usually think of with atresia is called tricuspid atresia. Well, where is the tricuspid valve? Between the right atrium and the right ventricle. Well, what's after the right ventricle? It goes to the lungs, right? There's no blood getting to the lungs. So how do we get oxygen to the body? That PDA. That PDA is an amazing thing that's there. So patent ductus arteriosus, we keep it open with prostaglandins. And if we're born with this PDA open, and let's say it's like, hey, that's great, but we don't need it. There's too much flow going on here. And you'll hear that murmur because this extra little tube is open because it's not really supposed to be there unless we keep it open because we need it, right? Now, sometimes we have to close it. And we can do that with a medicine called indomethacin, which is an NSAID. I mean, you use it for back pain. I mean, 40 years ago, that was the drug of choice, not ibuprofen, for back pain, believe it or not. So indomethacin is what we use. And what's the neatest thing that I found, because I'm a nerd, I mean, we're giving this indomethacin to this infant because he doesn't need this PDA open. I'm going to listen to that heart and I'm going to start to hear that murmur go away. And I think that's the coolest thing. I'm like, the PDA is going away. So congenital heart defects. We don't always know when we're going to get one. I mean, there's not like a writing on the wall. I mean, today with all of these special, infant echo, blah, all these things, yeah, but there are times where we don't know. So if you have a problem with your heart, the heart's going to tell you there's a problem, whether it's that rapid heart rate. That's why you have to know what your normal vital signs are. Normal heart rate for an infant, 140 to 160. Well, what if it's 200 at rest, the baby's asleep? The heart's trying to do something, right? Something's going on. I need to look. Also, that rapid breathing. 40 to 60 is normal. What if it's 100? And this is not uncommon, what I'm saying. These numbers are real. What happens a lot of time is you're going to see the blood's not flowing, fluid's going to collect in the lungs, and now you have an infant with congestive heart failure. Heart's beating fast, respiratory rate is fast. And you're going to listen to the lungs and you're going to hear all of this fluid going in there. Now, how is a baby going to eat when they can't even breathe? Their heart's already overworked. They're already breathing too fast. So these children are not going to eat. They have no oxygen. So these kids are going to be not gaining weight. They're going to be cognitively delayed until we can get rid of that fluid, make the heart stronger, and then the kid's going to go in the right direction. I mean, we've talked about coarctation of the aorta. Coarctation of the aorta is one of those things which show all of these symptoms. And that's one of the ones that sometimes slips away, sneaks out of the hospital as a newborn, and we don't catch it. Sometimes you have like minimal little pulses in the lower extremity, but this is a kink, a kink in the hose. The aorta comes off the left ventricle and it goes to the body. And somewhere it's kinked, which means down in the lower extremities, there's no blood. So what happens is, because it can't go down, you've got lower blood pressures down there. But up, you're going to see higher blood pressures because there's a lot of blood flow. But that blood needs to go somewhere. It can't go down, and it continues to pump. It keeps coming. So what it does, it goes back into the left side of the heart, up into the lungs, and it fills up with fluid. Again, congestive heart failure. So here we are, the PDA, like I said, It is from the lungs to the aorta, pulmonary artery to the aorta. Again, you hear that murmur. And as we correct it, again, that murmur goes away. And the other thing I didn't say is their blood pressure. Well, infants' normal blood pressure at birth is 60/40. That's a beautiful blood pressure. Children with an open patent ductus arteriosus are 60/12. Can you imagine? It's like, I know this kid has a patent ductus without even listening, because that is really wide. It's called a wide pulse pressure. So you'll hear that murmur going away when you treat it, if you're going to, and you're going to see that blood pressure go back to be 60/40. I've mentioned TGA already, and I've already said there's no mixing of blood, and the only way we can do it is that miracle little tube called your patent ductus arteriosus. We keep it open with prostaglandins. It gives oxygenation and it allows that heart to pump effectively. And then when we don't need it, we can give that medicine indomethacin, which will close it. We're going to see that pulse pressure come back to normal and the murmur go away. Again, atresia is nothing, no opening. And as I said, the most common is tricuspid atresia. I've never seen it on the other side, okay? Tricuspid atresia. There's no blood going to the lungs here. It is a problem. So how do we get oxygen when there's no other way? Patent ductus arteriosus, that's my oxygen. Okay, you've had surgery. You've had a tricuspid atresia, we've gone in there and we fixed it, or you've had transposition, and we've done the arterial switch. Whatever we needed to do, we did. Post-op cardiac surgery, you can have 1, 2, 3, 4, 5 chest tubes. It depends. It depends on the surgeon. Some of these kids that are older, we need to teach them what's going to happen. What do we do for a kid that needs to have the chest tubes removed? Number one, you're going to take a set of vital signs and you're going to medicate them for pain. You're going to be honest and you're going to let them know that even with what you're doing, it's still going to hurt a little bit after they remove it. I've worked in adult open heart surgery units, and adults tell me it's for like 30 seconds, minute, it burns really bad. And then it goes away, okay? These kids, you should have them sitting up so they can breathe after those things are removed. And you're gonna take, usually after the procedure, after you've explained it, after you have medicated them for pain, they're sitting up good, they've pulled them out, you'll take your vitals again. And these, again, always being honest with these children. So now you have these sites. You've got this open heart surgery, that zipper is a big incision. You've got these chest tubes. There's little, incisions there where those chest tubes were. So you need to take care of them. And they're going to go home with these wounds. They need to be taken care of. Make sure these parents are taught no lotions, no creams, no powder, because that can cause infections, okay? And they should only be clean as their surgeon, their healthcare provider says. It could be with alcohol, but this is all up to the physician, because you can get a bad infection with putting these other things on there. Transplants are something what we have to do even after we've done surgery, open hearts, and the heart just doesn't work anymore. The biggest risk is rejection, okay? I've seen many kids go through cyanotic heart disease, 3 open heart surgeries, plus all of these echoes and cardiac calves, and at age 8, they need a transplant. And I'll remember Thomas. On Valentine's Day, the day before, he said to his mom, tomorrow's heart day, and tomorrow I'm getting my heart. And he was very sick. He was close to death. 4 o'clock in the morning, they get a call. Somebody had died and they had a heart. and he had his surgery. That kid today is 19 years old and he still has the heart and he's doing really well, living a normal, full life. He is on anti-rejection medications for his life, but the kid is having a life. Rheumatic fever. This is one of the two, and you're going to learn this, I think, week 8 of the other thing that by strep, something happens. So strep throat, simple strep throat, right? No big deal. Well, if you don't treat it completely, or a pharyngitis that wasn't treated for whatever reason, can cause rheumatic fever. Rheumatic fever symptoms is fever, or a joint pain, a rash. You get these swollen joints and this chorea, which is shuffling gait and falling over. And that's usually when they end up at the doctor, like, this kid's not walking, keeps falling over, something's wrong. But the one thing that is the thing that we cannot fix, that will not reverse, is valve damage to the heart. And it's usually the mitral valve is damaged. And usually they need repair or replacement because of rheumatic fever. Now, how do we treat rheumatic fever? Well, it's due to a strep throat. So guess what? It's antibiotics. And they will correct everything except that heart valve. Now, digoxin is given to children, and it's given just like it is with adults. It's the same sort of thing. It might be a liquid, but it's still digoxin. How do you monitor digoxin on an infant? How do you know without a drug level if maybe they are in dig toxicity? Well, the one sign you might see is a decreased heart rate. Again, that's why we know normal heart rates in children, because digoxin is given in all ages of cardiac children if they need. So in an infant lower than 90, something's going on. And if you see an infant vomiting for no reason, or that retching sort of thing, like nauseous, do not give the dose of digoxin. Call the physician and do a digoxin level. The dig level is the same numbers as an adult. There's no difference, okay? So before we give digoxin on any age person, we're going to check the heart rate. We're going to check the potassium, like we would, low potassium, we're not going to give it. And we're going to check any frequent, recent dig levels. So that's digoxin. Now, when we get an infant congenital, so that's going to be an infant a lot of the times, we're going to get an infant in that we are suspecting some sort of congenital heart defect. We saw something in the echocardiogram. We know we're preparing for a catheterization. So we need to know how to take care of this child infant. So first thing you do when this kid comes back from a cardiac cath is, number one, check that bandage. They have put 2 different catheters into the femoral artery and femoral vein. And when it's over with, they pull these catheters out, they hold it, they put a pressure dressing on it. Maybe they have a sandbag on it on an older kid, but they've moved this kid from the table to the bed or to the warmer, or there's been a lot of jostling. Plus, bouncing down the hallways could have jostled, and that clot that was there could have popped off. You open up that blanket, you see bleeding, what are you going to do? Immediately, if you have a leg and the heart's over here, above it, 2 fingers, above that incision, you're going to put your fingers and hold it tight. And of course, you're going to call for the doctor. But the treatment is holding it until that bleeding stops. So pressure right directly above the insertion site to see it. And then again, the doctor will put another pressure, a bandage on it, and whatever instructions. What else do we need to know to treat this child? That leg must keep straight. Don't elevate it on anything. Keep it straight. Don't bend it. Don't do physical therapy. Leave the leg alone. Keep it straight. These children, whatever age, from infant to adult, bed rest, 24 hours. 24 hours bed rest, because we don't want to dislodge that clot. And vital signs should be done as written, but usually immediately. And then every 15 minutes till stable, and then whatever hour, 2 hours after, whatever the doctor wrote. We should, of course, again, always nutrition, whether it's IV fluids or PO, they can eat. It's not a problem. There's nothing to their GI tract, so they can. Now, infants, because they might have gotten glucose or they may not have gotten glucose during the procedure. So you want to make sure that they have enough glucose in their body. So we do a blood glucose, just a little stick when they come back to their room. So your concern is bleeding. Put pressure on it. If it happens, keep the legs straight, keep them in bed, monitor their vital signs. Give them fluids, whether oral, IV, and take blood dextrose. Idiopathic thrombocytopenia purpura, and it's also called immune thrombocytopenia purpura. Now, this is a condition that occurs usually after upper respiratory infection. And what happens is the platelets, somehow their count goes really low. These children usually come into the doctor or get treatment because nosebleeds, ecchymosis, or that is a great picture of purpura, this little purple little things. And the parent says, this kid doesn't go anywhere. He's on his iPad all the time, playing games. So there's no reason why he's bleeding. Something's wrong. So they're going to do a CBC. They do a CBC, and usually you will see platelet counts. 20,000 is a good number. Sometimes it's a lot lower. So thrombocytopenia is another word for low platelet count. Now, you're going to see thrombocytopenia in many other conditions, sickle cell, leukemia. Any child or adult with platelet counts low should be placed on bleeding precautions, because platelets work and help you not to bleed. So how do we treat ITP specifically? Well, again, bleeding precautions is the big thing. When they're put into your care in the hospital, we're going to give IV immunoglobulins. Remember, this is an immune thing. It's from a viral upper respiratory. Sometimes it happens, it's an acute stage and it goes away once treated. Sometimes if it's there for over a year, they say it's chronic and it could reoccur. It could be just one time. So how are you going to treat this child? They're in your hospital, they're in your team, and you need to take care of them. Well, you're always going to be teaching. Now, bleeding precautions. That means soft toothbrushes. Adolescents, sorry, you can't shave your armpits and your legs right now because we don't want bleeding to go on, right? Their platelets are low. We're going to watch their urine, their stools, the gums, see if there's any bleeding going on. We're going to be looking at usually they do daily CBCs on these children. Usually they have some sort of line, they can pull it off the IV so we don't have to keep sticking these kids, because no venipuncture if at all possible, because that venipuncture can cause bleeding and bruising. So everything to prevent it. Now, sometimes we need corticosteroids. Steroids sometimes work with this thing here, okay? Now, I'm going to warn you, there are some things between ITP and sickle cell that are different. All of this bleeding and counts, yeah, that's there. But remember, ITP has nothing to do with vessels being occluded. It does not need IV fluids, okay? Now, HIV in children. Now, usually when we think of HIV, we're thinking about the newborn infant that was born from a mother who has HIV. We can take that child and we can make them healthy. And we do that by supporting and making that immune system as powerful as we possibly can. Now, even as we're treating these children as a newborn, remember there are opportunistic infections that can happen. I think the most common you see is the respiratory system, which is pneumococcal pneumonia, PCP pneumonia. Sometimes you're going to see, the yeast, but those are candida. I mean, these are the two things that we'll see in them, but mostly the respiratory. So with those infants, as I said, let's improve their immune system. If we start giving, if the mother is very active in the care and seeing a physician, if that's what they're doing, we can start these really powerful antivirals at 22 weeks of pregnancy. And then immediately after birth, we'll be giving them antivirals, because what is our goal? We want to improve that infant's immune function. That is our goal, because these children could be born with HIV because of mom, but they can seroconvert because of all of the antivirals and supporting their immune system. And you usually will change to normal, no HIV, by about a year old. So keeping them, protecting them, preventing infections. Anemias, there's a couple. I mean, anemia is not enough red blood cells, low hemoglobin, low hematocrit. If you don't have nutrition for the body, which is your red blood cells, it's not going to be happy. It's not going to get oxygen, and it's not going to get iron to what it needs. So iron deficient anemia is the most common of all anemias in children, and it's due to nutrition. So how do we treat iron deficient anemia? Well, it is usually diet, increasing the iron in their diet. And then, of course, it gets to the point where there's PO oral iron medications or IM, Z-Track, Dextram. The thing about iron deficient anemia is that these children will be fatigued because their red blood cells aren't there and they don't have oxygen. So it's not giving to the body. So the children are tired. They're fatigued all the time. Megoblastic has to do with your B12, has to do perniscus anemia, which is intrinsic factor. Hemolytic is just these cells are being destroyed. We've all heard of sickle cell anemia. Remember, this has to do with those sickle-shaped cells that get clogged up in veins and they don't go through. And sickle cell anemia is something where the vessels are clogged and they need to be opened. Immediate treatment for sickle cell anemia: give IV fluids, make those vessels big, let those little sickle cells go by. So you're relieving the cause of sickle cell and the pain, okay? That crisis is due to those clogging of cells. Give all that fluid, open the vessels, give some heat and let it go through. And of course, you're gonna medicate them for pain. Thalassemia is from the Mediterranean people. We know sickle cell is the African American. Cooley's anemia is when the cells burst. Red blood cells, what do they have inside? They have oxygen and iron. So it's chronic depletion of oxygen and an overload of iron in the body. So these children, their cells are, especially the most severe case, which is Cooley's anemia, require blood transfusions to live. Aplastic anemia is white cells, red blood cells, platelets, they're all too little. Again, this condition is treated like leukemia, but we going to give blood transfusions. So getting blood transfusions, and you always give it by whatever procedure the doctor has you in. But if you've done a set of vital signs, 15 minutes later, you go in to recheck this child, they're flushed, they got a rash, they got a fever. Number one, stop that transfusion. Sometimes we're giving it and we see these things, shorts of breath, those jugular veins get swollen and they start coughing. This is circulatory overload. Again, stop. we need to call the physician and slow down that transfusion. As I said, sickle cell disease is when those vessels somehow hold those cells. They can't get through these bifurcations. They stick, they back up, it swells. It doesn't let blood go down to lower, so you have cell death, and it's swelling causes horrible pain. So number one, we need to get those cells through. We need to alleviate the cause, which is that clogging up of cells. IV fluids, number one. Then we can give something for pain. It's usually at the same time, but that and heat to open up those vessels, let the cells through. Now, there's a controversy about, do we give oxygen or not? Well, if you don't have red blood cells, what's carrying oxygen? Does it work or not? It's not really sure, but they will be getting lots and lots of blood transfusions because their cells die quickly. Now, children with cancer get a lot of chemotherapy, right? I mean, just think about, your leukemia. Our goal in the first part, induction, is to give whatever many types of chemotherapy, because our goal is remission. We want to kill it all in that first little bit. But they don't only just kill cancer cells. They do kill good cells like neutrophils. Neutrophils are types of white blood cells that fight infection. So the one thing, and it doesn't actually matter whether you have cancer or you're just another child in a hospital, but if you have a child that has a low neutrophil count, and it should be well over 1,000, close to 2,000 neutrophil counts. If we see a child with a low neutrophil count, 500 or less, this child has absolutely no immune system to fight infection. This child needs to get treatment, IV antibiotics immediately, because they can go into septic shock, especially if you already have cancer. So monitoring neutrophil cell counts on children with cancer, getting chemo, but also the normal everyday child, very, very important, okay? Leukemia is the white blood cells. They're immature. Well, what do white blood cells do? They fight infection. If you have nothing to fight infection, this is a child, it's a cancer. We need to support this child in order to get them back to living normal lives. We know leukemia is treatable today. It's usually those 2 to 5-year-old kids, they're young. And again, getting them prepared and all of that stuff is, that goes without saying. But they're given chemotherapy with all of these side effects. But what the goal is, that initial part of therapy is called induction. And the goal is to achieve remission. And you're like, remission? Yeah, eradicate all of those cancer cells. But remember, as much as we think they're all gone, there's always a couple there somewhere. That's why you're going to put it intrathecally, and you're going to be doing a prophylactic and, for a longer period of time. But those first 4 to 6 weeks, my goal is remission there. Using antiemetics before, and making sure that we're aware of all the side effects and helping these kids is what we have to do, because the outcome is actually really good today. Osteosarcoma is a cancer of the femur bone, usually. It is malignant. The whole femur bone needs to be removed. I mean, you start seeing a kid starts with limping, complaining of pain in the leg, and then you see swelling, and you do the x-ray and you see something going on, and that's what starts it. You start to figure it out, it's an osteo. They do a biopsy and then they decide surgery. They do chemo and they do surgery. And what their goal is to keep something there that they can attach a prosthesis to. And it can't be the upper leg. That's the femur. That's where the cancer is. That has to go away, has to be gone. So what they do is like this picture on the top. They take the lower leg, turn it around, backwards and put it back up into the hip socket, and they attach it there. And why do they do that? Well, you can put a prosthesis on that. If you can imagine that whole femur bone coming out, what are you going to attach anything to? You can't, there's nothing. So they will take the lower leg. Our goal is to salvage that limb, but sometimes you can't. Okay, so that's the amputation, but the goal is to salvage it, keep it there, to have something so they can be mobile. All right, so going back to leukemia, but it's not just leukemia, it's like bone marrows and taking care of bone marrows. Well, there are a couple different types of bone marrow transplant, and this is one of the things that treatment for a cancer like leukemia. It's even used with sickle cell. And what we have is two different types of stem cells that we use. So this is how I've told my class to remember what the difference of these type of stem cell transplants are. Well, or bone marrow. Autologous is automatically mine. It's automatic. It's mine. It works. It's automatically okay. And this could be things like your umbilical cord blood. It's mine. I can use it. Now, allogenic is other, everybody, everybody else. So everybody else is allogenic. Now, autologous is the most favored. If we have ours, there are autologous automatically. Yeah, that's the one I want. Not always do you have it. So they will go to the allogenic, which is everybody else. They do say that siblings are actually the best to use, but you don't have to be the same type, same relative, same nothing. But if you do have siblings, they do say it is better. Brain tumors. Brain tumors is something growing in the head, and it's occupying space and it's getting bigger. And the problem with brain tumors is you'll see symptoms, but you've got to be aware of these symptoms. Usually, because it's occupying space, increasing pressure, you're going to see headaches. But the headaches are going to be getting worse, a progression of symptoms worse. Also, pressure in the head causes vomiting. So it's not going to be related to eating or anything. They're just going to vomit. And headaches are going to be even to the point where it wakes them up at night. I mean, that's how bad they get. And that usually will give them the first symptoms that they'll be able to determine, all right, let's just do a simple head X-ray. And usually just a head X-ray, you can see it. The one thing about brain tumors, because they want to shrink it, they usually use radiation. Remember, there are these little purple marks they put there. Make sure the child does not take them off, wash them off. And then there's Hodgkin's lymphoma and non-Hodgkin's lymphoma. And how do I remember which one is which? Well, they're both has to do with the lymph glands, right? Lymphoma. Hodgkin's is one that you'll see a kid from the clavicles up only. Clavicles up, you're going to see a lymph node, and you might see this huge lump on this kid's neck. And you're going to say, oh my God, that must hurt. It doesn't hurt at all. It's non-tender, non-painful. You can move it around. And it's causing swelling, so it's irritating the airway, so you'll be coughing. Okay? Up there, they do a biopsy. They find the Sternberg read cells, and then they do chemo, and these kids in radiation, and they do well. And then there's non-Hodgkin's. Well, non-Hodgkin's is diffuse. That means it's not here. You don't see it. It's like all over the whole body, little sort of lymph nodes. It's not this really evident thing. Symptoms are the same, treatment's basically the same. They both have okay outcomes. I mean, it's going to go through the chemo, et cetera, et cetera. But again, Hodgkin's, you can see it. Clavicles up, it's upper. You'll see the big non-tender. Non-Hodgkin's is going to be all over the place, okay? And you're not going to see those lymph nodes as much, and they're just sparse all over. So you're going to have 5 simple dosage calculations. Make sure you know how to do mics per kilo per dose, figuring out doses. Make sure you know your heparin. Make sure you know your DHQs, and you guys are going to do okay. Any questions? That was a long review, huh? But we got you. All right. Good luck to you all.
Thank you.
Thank you.
Thank you, Professor Lillard.
Thank you so
Always,
much for everything.
always my pleasure. Any questions? I don't care if you're in my class or not. Just give me a holler, okay? Take
Thank
care,
you.
guys. My pleasure.